Hello, I'm Luis from InHealth Advisors, and I'm here to ask you the question, what's your problem? Whether you're a newly minted physician or a seasoned healthcare CEO, we here at InHealth are here to help you solve your biggest challenges in the business of healthcare in just around 5 minutes. So let's get started. Today, we're going to talk about primary care. Over the past couple of years, Medicare has significantly changed the way that it reimburses for primary care services. These changes represent a longstanding need to modernize the way that primary care is paid for in this country. In 2021, the National Academies of Sciences, Engineering, and Medicine issued a report titled Implementing High Quality Primary Care Rebuilding the Foundation of Healthcare. This landmark report represents the playbook, so to speak, that the Centers for Medicare and Medicaid Services have been using to enshrine policies and programs related to primary care. In this video, we'll examine some of the changes that Medicare has made to reimbursement for primary care services. We'll start by highlighting the key principles that Medicare has enshrined in its policies and programs for primary care services. We'll continue by exploring some of the new payment mechanisms associated with these policies and programs, and we'll conclude with key takeaways related to all these changes. CMS has adopted a number of key principles in payment for primary care services. We're going to take a look at three in this video. First, we're going to examine the shift from fee for service to capitated payments for primary care. We'll then continue by talking about funding for care coordination and team based delivery models. We'll conclude by looking at advanced payments to fund the infrastructure needed for high quality primary care. The quote that you see on the screen highlights the key problem associated with fee for service models in the context of primary care. In response to this challenge, the CMS Innovation Center has specifically developed models that target low revenue practices to assist them in the transition from fee for service to capitated reimbursement. In addition, essential to this process is risk adjustment based on the clinical complexity or health related social needs associated with the patient population being treated by the primary care practice. This next quote highlights the challenge associated with encouraging care coordination and team based delivery models. CMS has recognized that items like care team members and EHRs with quality reporting capabilities are not free but essential to practices. Within the Medicare physician fee schedule, this is manifested in new CPT codes that are intended to, for example, fund care team members. Within innovation models, we are seeing payment mechanisms per beneficiary per month, which are risk adjusted and intended to finance enhanced service capabilities. This third quote touches on the challenge addressed by Medicare's third principle in primary care payment, namely providing advanced payments to primary care practices. CMS recognizes that these upfront payments are necessary to help finance the infrastructure needed to succeed in capitated reimbursement models or value based reimbursement models. The upfront payments are usually subject to repayment in the form of future shared savings generated by the practices. With these principles in mind, let's take a look at how Medicare has implemented them, both in the physician fee schedule and innovation models, particularly the Making Care Primary model and the brand new ACO Primary Care Flex model. Within the physician fee schedule, Medicare has regularly been adding CPT codes that reimburse on a once monthly basis for certain care team member services, representing a hybrid of fee for service and capitated reimbursement. Well established examples of these services include remote patient monitoring and chronic care management. 2024 saw the addition of new codes for three big services. First, principal illness navigation. This is care navigation around serious conditions like cancer. Second, social determinants of health screening. This is reimbursement for administering a social determinants of health inventory for data gathering purposes. And finally, community navigation services. This involves connecting patients to necessary health related social needs service providers, like, for example, food banks for patients that have food insecurity. Two recent innovation center models involving primary care reflect implementation of the principles that we discussed earlier. Let's take a look at how these two models compare. They are the Making Care Primary model and the new ACO Primary Care Flex model. Both models contain a prospective primary care payment, which is a payment mechanism intended to convert fee for service reimbursement into a capitated monthly amount based on historical utilization patterns. Both models also incorporate some form of enhanced services payments. These are per beneficiary per month payments intended to fund additional primary care capabilities like enhanced care coordination and patient navigation. Finally, both models have a mechanism for providing upfront support for practices to fund the infrastructure necessary for success in value based care and working within a primary care capitated environment. So, putting it all together, what does this mean for primary care practices? First, it appears that Medicare is committed to their goal of having all beneficiaries within some form of value based reimbursement model by 2030. The new innovation models targeting primary care are focusing on trying to attract practices that traditionally have not participated, for example, low revenue practices. The second takeaway is that CMS is financing a lot of these changes by reducing the conversion factor associated with reimbursement for physician services in general. While they add new CPT codes that are intended to do things like fund, for example, care team members, they're financing that in a budget neutral way by cutting the conversion factor for all other physician services. Our final takeaway is that primary care practices should be proactive in taking steps to address the changes that have occurred and are occurring within primary care reimbursement. These steps include things like building out the financial and operational data infrastructure needed to succeed in a capitated or value based reimbursement model, innovating in the care delivery models in order to make the best use of care team members in delivering primary care. And finally, refining compensation models to make sure that provider effort is aligned with the goals associated with high quality primary care and reimbursement on a capitated basis. So let's review what we covered today. First, we discussed the new principles that Medicare has adopted for reimbursing for primary care. The first looks at shifting from fee for service to capitated reimbursement. The second is encouraging care coordination and team delivery models, while the third involves advanced payments to fund the infrastructure for primary care. We then took a look at some examples of these payment types within actual Medicare payment models. We looked at some of the new CPT codes that were implemented as part of the physician fee schedule in 2024, as well as some of the payment policies that are attached to Medicare's new primary care innovation models. Finally, we concluded by taking a look at three key takeaways for practices to implement based on these changes and principles that we've highlighted. If you need help navigating any of these changes to the primary care reimbursement landscape, the experts at InHealth Advisors are here to help you today. Oh, and if you find this content useful, feel free to subscribe to this video channel. Thanks, and we look forward to talking to you soon.